Good morning, everybody, and welcome back to the second day of the colloquium, Reimagining Dental Public Health Through Resiliency and Community. We have an exciting day planned. We're going to start off with a panel discussion, and then we're going to follow that with a breakout session. And finally, at the end, we're going to wrap it up with a call to action. So I want to remind you to stop by and visit the virtual poster session. There are 13 posters that are available for you to review. Each presenter, along with their poster, provided a 5-minute discussion of their work. I want to take this opportunity to thank each of the poster presenters for sharing their scholarship with us. I can tell you that the work that's displayed is impressive, and I encourage you to take the opportunity to visit the poster sessions. I also encourage each of you to participate in the discussions. The program was designed to allow maximum participant input and to drive the discussion in the area of topics that are of greatest interest to you. So please ask your questions, share your experiences, and let us know your point of view. By engaging in the conversation, you enrich the outcome of the colloquium. I want to take this opportunity finally to also thank our sponsors for the event. We so appreciate their support. I want to thank the American Dental Association, DentaQuest Partnership for Oral Health Advancement, Delta Dental of Iowa, the National Network for Oral Health Access, or NOAA, and Mouthwatch Teledent for their support. So with that being said, let's go ahead and begin this next session. I'm David Capelli, the chair of the board of directors for AIDPH, and I'm delighted to have this opportunity to moderate the panel to discuss how to respond to our changing health and oral health infrastructure. We have an exceptional panel today, and the panel is here to discuss your questions. I ask that you type your questions into the question feature in Crowdcast that's located on the bottom of your screen. It's on the bottom right corner of your screen where it says Ask a Question. We have 3 distinguished panelists for today's discussion. Dr. Rochelle Rollins is a senior policy advisor at the U.S. Department of Health and Human Services. Dr. Irene Hilton is a consultant with the National Network for Oral Health Access, or NOAA, and a dentist with the San Francisco Department of Public Health. And Ms. Rachel Davis is the executive director of Prevention Institute. So please join me in welcoming our panelists to the stage today. So I'd like to thank you all very much. I'd like to start off with just sort of a general question. We're looking at how we can move forward with person-centered care or health care. What programs or policies are currently in progress at your level, or do you see at your level that could address health disparities? What are some of the things that's ongoing in your area or your sphere that we can talk about that would address health disparities? So, Dr. Rollins, we can start with you, if you like.
Sure. Can you hear me?
Yes, thank you.
Glad to be here, and I'm with the Office of Minority Health. So disparities are what we focus on in OMH at the across HHS. What's happening around oral health disparities? There's a lot of activity within HHS. We have a very active Chief Dental Officer, Reverend Tim Ricks, and we have Chief Dental Officers across HHS, and we are meeting regularly and looking at the issues of the day, whether it be fluoride, COVID, etc. As most people know, there is a Surgeon General's report in process. I have a role with that review and clearance process, and that should have a focus on health disparities as well. I want to also say something about HRSA. Our community health centers are very active under that Chief Dental Officer, Captain Renee Josco, and integrated healthcare is an important part of decreasing health disparities, especially in oral health.
Thank you. Thank you. Ms. Davis, your thoughts about how we can, your thoughts about what's happening to address health disparities in your area.
Yeah, thanks so much, and thanks for the invitation to be here. I want to come at this from a different angle. Maybe people might have noticed there was no dental in my title. So I come from the sort of field of public health and community health more broadly. And years ago, actually, for the Office of Minority Health, we developed a tool called Thrive, which is the tool for health and resilience in vulnerable environments. And that tool is really about understanding conditions in the community environment that impact health and safety and well-being. And so being here has given me a bit of a chance to think about that in the context of dental health. And I've been thinking about, what are those community conditions that support better dental health? And I'm reminded of when I was in the San Francisco Unified School District, working in schools there. And every morning we asked the kids, little kids, to turn on the water for, however long they had to turn it on so that they didn't get exposed to lead. And that seemed ridiculous to me. So, we worked with the school district to change the pipes so that we weren't asking kids, 5 and 6 year olds to count how long the water had to be on so they weren't exposed to lead. So I think about that in the context of dental health. And, do people have access to healthy food in their neighborhoods, or a transportation system that supports them getting there? Years ago, we did a study called Where's the Fruit? And we looked at the 100 foods that were most marketed to children. And for every one of those that had the word fruit in the title or fruit on the picture, we analyzed the fruit content. And more than half of that had no fruit at all. And only 25% kind of had, what you might consider fruit. So how are we creating the options in communities that support, in alongside good clinical care that can really support good dental health outcomes? And in this current context, in the context of COVID, with schools not opening and knowing that's both a place for healthy food, but also for, clinical access to dental services, I think it creates new opportunities for us to think about how can we reach the most vulnerable populations at this time.
Thank you very much for sharing that information with us. So I wanted to ask you too, where do you see, so that was very helpful understanding sort of what we have ongoing right now and what we're, what work you're doing. How do you see in the future that we could actually promote the concept of whole person care in what we do in the existing healthcare system? So sort of adding to, or how could we build in the future the concept of person-centered or whole person care? Dr. Rollins, we'll go ahead and start with you.
So patient-centered care has been around for a while.
Mm-hmm.
I think we need a much stronger focus on oral health literacy. And that can get us into the door of understanding the connection with the whole body. If common everyday people understand the literature, not the literature, but the terms around oral health and how it connects to the body, I think we can achieve some better well-being across the board. In addition to oral health literacy, I think we still, we being oral health community, still struggle to get visibility in the topics as they come up, even for something such as COVID. And we need to be at the table. We need to be thought of as strong healthcare providers, necessary healthcare providers, and there's still work to be done to achieve that.
Thank you. Ms. Davis, your thoughts?
Yeah. So, I mean, again, I can offer some ideas that we've done outside of the dental realm, and leave it to those of you sort of more in that space to think about how this might apply. But a number of years ago, we developed a framework called the community-centered health homes, and that notion is the notion about working with community clinics to help understand that most of the reasons that patients are coming into those clinics to seek treatment have to do with things going on outside the clinic walls. And so then there are questions about what is the role of clinics in partnering with community and other sectors in community to support strengthening community environments. And so again, in terms of this sort of notion of infrastructure, and you talked about whole person care, that this notion of community-centered health homes really came out of the notion of patient-centered health homes. But how do we sort of treat the community and support strengthening the community environment? So, in the social cultural environment, how do we strengthen sort of trust or norms and culture around, dental care or, eating practices that can support healthy dental outcomes within sort of the context of the built environment? We look at what's sold and what's promoted within the community, and how do we ensure access to healthy foods and not over marketing of sugar, et cetera. And how do we support, families to be able to afford those kind of healthy options? So I think that there's a connection between what could go on clinically in dental care and really just building out a broader understanding of how all these factors in the community environment can support improved dental outcomes as well.
Thank you. I'm going to try to, I don't know if we have Dr. Hilton. She's sort of been in and out of our session with us. I don't know if she can respond right now. Irene, can you hear us?
I can hear you. Can you hear me?
I can hear you. I can't see you though, but I can certainly hear you.
Okay.
So would you like to respond to that question as well about how we can, because you're specifically a dentist and a public health dentist, can you tell us how you see that we can promote the concept of whole person healthcare in the existing system that we work in?
Yeah, thank you, David. I hope, like I said, my internet holds out long enough. But it's great to be on this, I guess now call with Rochelle and Rachel. And Rachel, I'm from San Francisco. I'm at the San Francisco Department of Public Health. So I think that we have had a lot of the same experiences and same influences. Just to go back to like your first question about what might work on the clinical level, I think some of the things that are working, and this is within like the current contextual framework of healthcare delivery and healthcare payment that we have. So without blowing up the entire system, which we could also talk about, one of the things that I think is working and is starting, is kind of on the ascension curve. So it's still not the like everyone's doing it, but let's say a critical mass is building, is this concept of integrated care, and again, team-based care and having oral health kind of be a part of that. That's I'm not going to say the easiest, but again, within the current system is a type of delivery system that could lead to improvements and a reduction in disparities. That includes that the idea of oral health literacy, like I said, is part of whole person being literate in terms of all disciplines in healthcare. But to speak to, like, I think what's a long-term and possibly like really, like I said, an underlying concept to, again, improve oral health care and disparities is just like, I'm gonna say in its infancy within oral health, we'll say within for dentists, because again, there's just like a few people that are really in the realm of it, is this idea, of tying in the social determinants of health and understanding, this is at the individual patient provider level, and then at the systems level, why people eat what they eat, why do they drink what they drink, what are the factors that don't allow them to make healthy decisions, and so again, what Rachel referred to in the school district, again, this is like just one example of the intersection of the social determinants of health, the built environment, chronic disease prevention, and oral health.
Thank you. Thank you all very much for your thoughtful responses. We have a couple of questions now from the audience, so I'm going to go to those right now. The first question we have, and did you want to, Katie, promote those individuals and allow them to ask the question, or okay, so our first question is from Dr. Geierman, okay? And so so the question is, with the graying of America, can either of you suggest how we can begin or continue to address the oral health disparities of our esteemed elders? So who wants to tackle that one? This is an issue we're all worrying about, not everyone, but I certainly am.
I'd like to start, David.
Sure.
So within HHS, we have something called Administration for Community Living. And we had up until a month ago, a very active member who brought all those issues of the elderly, older adults to our oral health conversations. And we have a substitute now going to take his place. But I think we need to have stronger advocates, and we need to have them more connected to government and private sector systems, so that when we talk about oral health, the elderly is straight there, always there. I remember back when, this is dating myself, back in Healthy People 2020, I worked very hard to put oral health in the new topic area. Back then it was new, called older adults. And so looking at geriatrics and older adults. I'm not sure if that is going to be part of Healthy People 2030, but we need to make those connections between topic areas and Healthy People 2030, which is going to be launched in a couple of weeks. So I'll say that.
Thank you. Other thoughts?
Well, this is Irene. I think the first thing, and I think everybody on this conference knows this, that unless you address the payment issue and how you're going to pay for elder oral health care, whether it's as a carve out or as part of some kind of global, you're not gonna get it. Just like in our existing payment system, where 70% of elders over 65 don't have insurance. So I think that's like the first piece. And then I'll just say from a clinician perspective, it reminds me a lot of where we were 20 years ago with kids, with really small kids, like 0 to 3 or 0 to 5, where the general dentist, I'm not gonna say was afraid, but they hadn't really had the training. There was a combination of thinking that you didn't go to the dentist till you were 3, so the general dentist didn't know how to do kids 0 to 3. So in the same way, many general dentists, once go over 65 and get into the elder, and people start to be compromised, may feel that, again, just insufficient training and understanding, and feel that it's like a specialty or just can't, so it's the two ends of the life cycle, are kind of on the outer, not in the mainstream of dental care. And so that's, something else that would have to be addressed. And then, like I said, going into where do the social determinants come in there also. And then certainly in terms of elder care, it has to be in the context of the community, because, seniors will be getting you go back to the whole person care model and how oral health would be incorporated into the rest of health care and wellness. So those are models that have yet to be developed.
Yeah, and so I would just add to that again, looking at what the barriers in the community might be, or the strengths and opportunities to build on. So, some of the things that come up for me are, around either, transportation and sort of access that way, or, how services are clustered together, or norms around dental health and accessing dental care. And then the other piece I would just add, as we're all sitting here in a virtual meeting because we're in the midst of a big pandemic, that I think there's a lot of fear about going out and going to places like dentists. And so how can people be supported in that and assured their safety at this time? Because I think that's really something that's at the top of a lot of people's mind. And that can both be, seeking care, but also in terms of, transportation to get there.
Right. Thank you. Rachel, specifically, do you see that since the oral healthcare system is very separate from other healthcare systems, do you see that as a primary barrier as well, or is that not so much of a barrier for others, for seniors especially, to access services?
I mean, I could sort of wield a guess at that. Years ago when we were developing the Thrive tool I mentioned, and we piloted it in communities, and in one community in particular where we had a number of seniors, that their primary initial take was they wanted a one-stop everything. And that included, the pediatrician in the same place as, the dentist in the same place as geriatric care, et cetera. And so that notion of one-stop, I think, is really, came through there. I think some of this is probably cultural, and asking the communities that you serve, what's going to work for them, and how that starts to connect to their own culture and cultural practices in ways that it starts to feel more accessible, I think is an important consideration.
Thank you. Thank you all very much. We have another question from Annalise. Did you want to ask the question?
Sure. Hi, everyone. I'm really interested in hearing about resiliency. This concept has just, to me, been really poignant, especially since the pandemic, and seeing how people have really been resourceful and feel this sense of community and in light of all the bad stuff that's happening. So I was interested in hearing your take at how we can promote resiliency at different levels, in the community and local levels, the state levels, and the federal levels. And then also if anybody has any thoughts on those upstream factors that can promote resiliency, in a more preventive upstream way.
Well, I'm gonna
go ahead.
I think in terms for resiliency, I'm going to use the example in San Francisco, which was what happened with the soda tax funding. I don't know if you know, like I said, San Francisco, we're in our 4th year and we have soda tax funding. And part of it relates to the structure of the advisory committee that we have, because it's composed of 16 people that are representative of groups that have been disproportionately impacted by the negative health outcomes of sugary beverage consumption, and also from agencies that address these issues, and so the funding has been going to things like to the schools, for healthy food, but also for student-led action, to the Office of Economic Employment, to subsidize, counter-subsidize, sugary beverage industry placement, within corner stores, to tap water, healthy water consumption education, to oral health, to community agencies, things like that. And so this is a very community-led, community-centered, the whole, passing of the soda tax, and now the advisory committee, it's very, of the community. It emanates from that. And when COVID came, what we decided as a committee was to take all the excess funding that we had, because it was actually $1 million out of the 10 million that for various reasons, hadn't been spent. And we put it all into food security, and the mayor agreed, to have to do food. So for people, like I said, because that's an issue now, especially with essential workers. So I think I'm just saying that that's an example of resiliency in terms of the communities themselves know what they need. And so at that moment, based on whatever it is that's going on. So if you create system, if you have opportunities, that like this, like the way the soda tax is administered, to allow that flexibility as things change, then that fosters resiliency in the community. It's being given the opportunity to have that, to be able to control, something.
Thank you.
I like to add something to what Irene just said, because resiliency does have to start at the local level. And in preparing and thinking about this today, I was thinking about rebuilding, reimagining, reframing the work that's happening. And a good example is in the state levels, our offices of minority health are looking to see where the gaps are in terms of communities. There's a lot of pain and suffering going on, of course, in low income and minority communities. But resiliency, bouncing back, is not new to low income and minority communities. One of the problems right now is our launching point for bouncing back is so much lower now. And so we need to use the expertise of individuals at the local and state level, because at the federal level, I think we're a little far away from the problem. And we can build the systems, we can communicate with the state and other private sector leaders, but the answers are at the local level.
So I'd like to just add to this as well. So we look at resilience at a community level, and based on our work with communities, we've defined community resilience as the ability or capacity of a community to adapt, recover, and thrive even in the face of adversity. And we know, and I think Irene just mentioned this, there's a long history of resilience and bouncing back from a lot of challenges ongoing all the time. And sometimes that term resilience gets kind of heard or perceived as, you're just telling us we have to keep dealing with all this crap that's coming our way. And I think it's really important to balance out that the building resilience can become, or supporting communities to build their own resilience can become, part of what gives them more agency and efficacy, honestly, centered around hope to start to change their own conditions. So, and right now, I think because, COVID has just really revealed, what we already knew was true, that there's really gross inequities in across the board and all kinds of things. And that's bringing up, on the one hand, more hopelessness. And on the other hand, I think goes part and parcel with a national uprising calling for racial justice in this country. So, there's a lot to build on. But I also think just recognizing the sense of hopelessness and overwhelm, and particularly, as this pandemic goes on, and, at one point feeling like here in California, we had flattened the curve. And now, for example, we're spiking here. And that's particularly true in communities of color. So, I think, engage. I love the example around sort of the creating the opportunities through the sugar tax to really support and engage communities in being part of the solutions moving forward, creating those opportunities. And what we're seeing increasingly in the work we're doing with communities is just really explicit discussions around power and shifting power to the community. And part of the work we've been doing is both supporting community groups to take that power, which starts to look like things like participatory budgeting and, community decision making. But just as important, if not more important, is the work we do on the other side with the systems and sectors that hold the power and hold the resources, and helping them let go of those so that those really can flow into community.
Thank you. Thank you very much for that thoughtful response. We have several audience questions, so I'm going to go right to those. Now, I want everyone to be able to ask their questions from the audience. We could, the next question, if we can ask, would we like to elevate Colin to ask his question if he's interested in doing that? Hi, Colin. Thank you would you care to ask your question?
Sure. Yeah. So I heard a lot of talk about team-based care and integration, and there seems to be a general recognition of the value of moving in that direction in order to better address the needs of a population, to take advantage of existing touch points and ensure that oral health is addressed beyond the dental clinic. But it seems that one of the major barriers that we're still facing is sort of lack of integration of systems, disparate coding structures. So I'm wondering if the panelists can talk a little bit about how they see us overcoming the barriers of, for example, EHR integration, and any progress that may be being made in that space.
Thank you.
Oh, Irene would love to take that one.
Okay.
And I'm looking at it through the lens, of working for 35 years, in federally funded health centers, right, in FQHC. So on one level, look at all the different kind of like structural models of all the levels of integration. At the health center setting, we've solved one aspect of it, which is the location, as Rachel said, the one-stop shop, more or less. But as that's just the beginning of it. The barrier, there's still multiple barriers, but we'll say the first one is still the IT piece. That's still the predominant barrier, where you run into the challenge of, how far does government intervene and the market in terms of dictating that, all healthcare technology systems should be interoperable, because that interrupts the market. But until you have that, that's really the only way that you could get, universal interoperability and the ability to have portable health data, so that even the patient themselves, could look at their own data. I shouldn't say even, like that's the last thing you think of is looking at your own health data, which I'm saying it's kind of messed up in that way. So that's kind of like the first, the most overarching issue. If the technology doesn't facilitate the integration, people have to consciously decide, on X system versus Y system. And then the other one, there's many other pieces, but one that David and I talked about actually was the fact that the education system, for healthcare providers doesn't model this, because many the dental school is on a different EDR than the medical school or the hospital system. So if you aren't trained, in a really integrated system, how can you practice? You're always, if you don't do whatever it is you're trying to do, whether it's expose people to social determinants of health or integration, if you don't do it during the training process, it's so much harder to acquire those skills once you're out as a practitioner. So those are just like two high-level thoughts.
So, just a couple thoughts, not being in the system. So I hope, Colin, this feels relevant somehow, but in, the broader sort of public health and social determinants of health world, by and large, people still think health means access to health care. And if you listen, for example, to presidential debates, everything around health is around access to health care. So, my assumption is that the understanding of dental health is really in the context of access to dental health care as well. And that even as in public health and health care, there's been this sort of growing use of the language of social determinants of health, that when you unpack it, it almost always, particularly in the healthcare realm, almost always means individual health-related social needs. So it's not so much about changing a transportation system that works for communities. It's about getting someone to a clinic. And so we've been, really sort of struggling with how do we move a system that addresses the social determinants of health more broadly. And, I really think picking the data and indicators that drive that is going to be really important, because all systems sort of produce what they're supposed to produce in a way. It's just, so it's a notion of how do we re-envision what we want the system to produce, and then use the data to drive that. And so that could be about creating a different set of indicators or markers for what success looks like, or that drives systems in a different kind of way.
Thank you. So we can move on to the next question, and that's from Dr. Fossey.
Hi, everybody.
Hey, how are you?
Good. Thank you for the opportunity to ask my question. And actually, it's building very nicely off of what you were just speaking on, Rachel. So thank you. And I wanted to kind of drill down a little bit specifically on the transportation piece, because I think that's one issue in dentistry that we haven't been trying to confront maybe as mightily as others who do community-based healthcare have. And, for instance, and I admittedly don't know much about this realm, but I'm not sure how much dentistry is really using systems like non-emergency medical transportation, or, building community-based partnerships to ensure patients that the transportation barrier is not an issue for patients. So I'd love to hear about just any, if you know of examples of health centers, hospitals that are doing, that have partnerships in place in their communities to address this. I think we have a lot to learn from others outside of dentistry in that regard.
Okay.
I think it's transportation is such an important issue, and again, it's coming up here in the context of getting folks to clinics and to appointments, and I have seen, this is where I've seen some of the stuff related to individual health related social needs around vouchers for car services or those kinds of things. I think that more broadly, it's important to think about that if folks are having a hard time transportation wise getting to an appointment, they're probably also having a hard time getting, for example, to a place that sells healthy food. We know that in some communities that have either been called, food deserts or food swamps, that there's, a disproportionate amount of unhealthy food related to healthy food. So I think that for me, that starts to create opportunities to think about the kind of partnerships that you could have to start supporting a better transportation system that really works for communities that are most vulnerable to a whole range of poor health outcomes that also includes dental health, and really look at those underlying structures that could support better access to all kinds of opportunities for better health. So, I can't sort of offer a very specific example around something that I've seen around access to dental health care, but I do think having a transportation system that works for communities is really important. And I think back to this study that was done a number of years ago that was able to show that for every supermarket in an African American census tract, fruit and vegetable intake went up 32%. And in white neighborhoods, it only went up by 11%. And the author's conclusion was that related to transportation access. So there's something about both having healthy food there, but also having the transportation systems that support access to healthy food, which can also support, better dental outcomes.
I'd just like to add that I would love to know about any promising practices that are connecting transportation and oral. I don't know of any great examples. Our Region 1, which is New England, does a lot of significant work on oral health and minority populations, but knowing those best practices would be helpful.
Well, I will tell you, time got away from me, and I was so engaged in the conversation that we ran a little late. I thank you, all three of you, very, very much for your thoughtful comments today. It was a wonderful session. I appreciate your participation. I'm going to turn